but great guy. So anyway, moments of silence, please. Please be seated. And Devin, when you're ready, roll call, please.
Councilmember De La Rosa?
Here.
Councilmember Lavelle?
Here.
Councilmember Schickling?
Here.
Mayor Pro Tem Ponce?
Here.
Mayor Marshall?
Here. Are there any announcements or written communications?
We received 2 written communications regarding the medical center presentation. Copies of both letters have been provided to all the city council members and are part of our original record.
Thank you very much.
And Mayor, if I could, I'd also like just to point out, it's our first meeting of 2024, so AB 361 is no longer in effect, so the city will not, or is not under the operation of remote participation anymore. So if there are emails coming through, we're not monitoring that like we used to and giving feedback. It's obviously the meeting is still broadcast, but we don't have the remote participation.
Oh, okay. All right, thank you. Anything else to report, City Manager?
No,
Okay. City Attorney with us?
he is not tonight.
Okay. Oral communications, this is an opportunity for people to speak on items that are not on the agenda. You will be limited to 2 minutes and no action would be taken. Okay. Do we have a presentation this evening?
Can I say something?
Yes, please.
Because I know that there was talk about changing public comment. I just want you guys to know that when we're done with the presentation, there is no public comment. So if you have something that you want to say, you need to say it now. And it's because what they're doing is they're doing a presentation on everything. There is no discussion on everything. I just want people to understand that this is your chance, if you have anything to say it, because there won't be that back and forth after the presentation. Because it's a presentation.
I don't think there needs to be back and forth, but I was hoping that there would be an allowance if the hospital is amenable to having
Then
questions asked.
We'd have to get that approved by them if they
Sure,
want to do
sure.
that.
But having questions asked for the sake of not necessarily replying tonight. I know that you may not have answers for questions tonight, but to be able to respond to the community with the answers to those questions at a next meeting or at a future town hall.
Because I don't, because I know that the public comment is just going to be a big, and I don't mean to be out there, it's just going to be a bitch session. So that's what public comment's going to be tonight. People are going to throw out all the stuff they find that is wrong with the hospital, and that's not going to be helpful. It has to be open communication between the two groups. I just don't want this to become a free-for-all on, because I've already heard, I've seen things, I've heard things, all these things that people are saying out in the community that they need to hear the facts. So I just want them to hear the facts.
Sure.
Okay.
So,
And just,
with that said, what if they come up here, for 2.5 hours and spill their guts and all that kind of stuff? But if they had listened to the presentation, then half the stuff wouldn't matter. That's, that was a different meeting, but that's what it felt like to me. It's like if you hear the presentation, then you know what they're talking about, and then you can
Ask
either
informed questions.
reframe your comments or ask a question or something like that, where, if you put it beforehand, that feels to me like a waste of
okay,
time.
but we just have to set the rules
Yeah.
right now as to what's going to happen once the presentation's
gotcha.
over. Okay.
Can I make a suggestion? Just allow the hospital make their presentation and then open the podium up for comments for the residents that are here. And if there's questions that can be answered at a later date, we can get those answers. But, I'm sure that many questions will be answered by the presentation, but you still allow the public to make comment afterwards.
Okay, is that?
And I'm not saying they shouldn't be allowed to make comment. I'm just saying
Right.
there's a way of doing it.
Right, but also know that after the presentation, if you do come up and talk, there will not be back and forth. You can state what you have to say, but the hospital is not obligated to respond and will not respond, and, you know, same with us.
Is that clear? Okay. Let the presentation begin.
That was a very confusing conversation. So, well, thank you for giving us some time to talk. I also came with me is some individuals, some experts from the California Hospital Association to inform the community and also the City Council of what is the state of healthcare in California and the United States. So if you would like for them to, they've prepared talks to kind of, because this is an educational thing that we're trying to do, and get the community involved in the future of our healthcare. So would you mind if?
Well, I consider them as part of the presentation.
All right.
Hello. My name is Peggy Wheeler, and I'm a vice president on the policy team at the California Hospital Association in Sacramento. So I came down yesterday at Jason's invitation. I'm primarily here, as you've indicated, to be able to answer questions, take them back, provide written response to those questions. But I am here primarily to talk about healthcare in our hospitals at the state level. My role at the Hospital Association, and I've been there 18 years, is to work with our small and rural hospitals. So for 18 years, I've been working with those hospitals that are considered by the state of California to be rural. Within that group of 56 hospitals, there are 37 hospitals, like the hospital here on Avalon, that are called critical access hospitals. Those are our smallest, most vulnerable, most remote, most rural hospitals. They have to have 25 beds or less, have to be certified by the federal government as critical access. What we are seeing across the board post-pandemic is an attempt to recover from something that none of us could have expected during COVID, where by virtue of the nature of that pandemic, we asked all of our hospitals to turn off all the ways you make money. Stop seeing patients, stop doing surgeries, stop doing procedures. And we are in a period of recovery. But what we have seen across the board is that hospitals are recovering very slowly. Two things are occurring. The expenses that hospitals needed to incur are still very high. So the salary expense has gone from the comparison in 2019 versus 2020 at 4% of cost to now 19% of cost for salary expenses. Has a lot to do with the fact that we moved into a period of time where we were using agencies to get our nurses, and we're trying to recover from that. But in addition, all purchased services are still at a very high rate as a part of the expense of providing care, and we're just now starting to get our patients to come back into our hospitals. But for these most vulnerable critical access hospitals, whereas all the hospitals in the state are recovering at about a 1.6% positive operating margin, the 37 critical access hospitals are still at a negative 3.1% operating margin. And that's for all of those hospitals. Rural's in the same situation, but 62% of the 37 critical access hospitals are operating with negative operating margins. So I just wanted to set the stage that what you might hear today about the financial turmoil that this hospital is experiencing. Jason is in collaboration with his colleagues across the state because they're all trying to deal with this financial turmoil. I'm here to answer any questions that you might have. Please feel free to call upon me. The state of California, the California Hospital Association is here to support the survival of this hospital.
Thank you very much.
Peggy, real quick,
Yeah,
you
it's
mentioned the
questions.
4 to 19% salary expense. Is that all throughout California?
That is all throughout all of the hospitals in California, yes. If you'd like it broken down just for the critical access hospitals, I could do that, but I wanted to set the framework that all hospitals are having a difficult time right now.
What is the reasoning for that increase? Is it a decrease in the cost of goods, so the commensurate salary looks higher and the percentage is higher? Like, I don't understand what that is.
Well, a couple of things are happening. You may have heard that just in the last budget cycle, in the last legislative cycle, a bill passed to raise the minimum wage
Sure.
for workers. So, and they raised it both for fast food and for health care, and so now there's that competition. But during COVID, agencies overinflated the cost of getting nurses into hospitals, and it's been difficult to come back down from that. And
Because
now-
of utilizing traveling nurses, or for what reason?
for utilizing traveling nurses.
Okay.
So these agencies came up and were able to give you traveling nurses, which we needed, because you may have heard that many nurses retired from nursing during COVID. So in order to get nurses to work in our hospitals under the conditions that they were working in, these agencies were charging hospitals a lot of money to do that. That is hard to come back down from that. And now in California, based on contract labor, we have increased salaries, and it's going to impact small and rural hospitals. By 2033, they're going to have to be paying a minimum of $25 an hour.
Okay. And then for the California Hospital Association, is that a state-run association or a nonprofit?
No, so it's not a
Organization?
state organization. The California Hospital Association supports 441 hospitals in the state by the dues those hospitals pay.
Okay. Thank you.
Great questions. Thank you very much.
Thank you, Peggy. I'm Mark Gamble, Chief of Advocacy and Operations for the Hospital Association of Southern California. So we represent about 200 hospitals here in 6 southern counties. And it's great to be back on Catalina. I've spent more than a few summers at Camp Fox. I was born and raised in LA County. And in fact, I think I still have the drop line I won on the pier in a fishing contest probably 15 years ago. I'm not sure it's usable anymore, but I still have it. So, and we're here to support Jason and the community because this hospital is critical to the residents and visitors of Catalina Island. And as Peggy alluded to, there's a number of hospitals in the financial constraints right now, largely on the heels of the pandemic. To put an emphasis on what Peggy was talking about, operating expenses have gone up to $23 billion higher than what they were pre-pandemic, and that's for all hospitals in California. And I can tell you, the hospitals here in Southern California, for a number of factors, are struggling more than many up north. But Peggy's not allowed to say that because she represents the whole state. We're Southern California, and we always think that we're getting the short end of the stick, just like other counties think LA's always getting the bulk of the money. So the threat of closures and downsizing isn't just happening on small rural hospitals. In fact, there was a day last year where you may have remembered Beverly Hospital in LA County filed for bankruptcy. It was also the same day that Cedars announced layoffs. So you know when an institution like Cedars is laying off staff, the financial constraints are real. And then last year,
I'm sorry, I was just pointing out a seat that's available.
oh, okay. I thought you were telling me to sit down. No, it wouldn't be the first time. Madera Community Hospital up north, a small rural hospital, closed and left that community with no place to go for care, so they are having to go great distances now to seek health care. And so, again, we're here for Jason and the team. Adina, my colleague from LA County, who works with all the hospitals in the county, has been talking to the county supervisor, Janice Hahn's office, about potential funding sources. We're looking at how maybe LA Care might be able to help out, or at least point us in a direction where we can find financial assistance. So we are committed to help you all and Jason as you work through this, and look forward to the presentation and discussion tonight. And we're here for as a resource. Thank you.
Yeah, thank you very much, Mark.
But, so Karen, I'm sorry, Karen, you said that all the hospitals closed down all of their money-making activities and all that kind of stuff, right, during COVID? But ours stayed open. They separated out the swing beds and all that stuff, so there were still people in the beds. And then the ER and all that, because people were sick, it was a pandemic, so it was open, and then
That's the real misconception of what happened during COVID. You'd think when a business is bursting at the seams with customers, that they would be doing extremely well financially. Hospitals lost significant sums of money during the pandemic, and you heard about all this money that the feds sent out to the hospitals. That was formulated that was based on a formula that calculated the number of patients in beds at a set point of time, which happened to be before we had the surge here in Southern California. So we didn't have, when they made that calculation on how to bail out hospitals, our numbers were significantly lower because we didn't have that surge. Our surge didn't hit until about this time, 2020. And so that's part of the problem. So then, and the hospitals had to cut out all the elective business where they generate the revenue. And so, and the cost of staffing, as Peggy alluded to, went through the roof, and nurses left, physicians left, and they haven't come back. And so that's part of what's driving up the labor costs.
Can I just make a comment? I was chair of the hospital board as COVID hit, and then resigned the day before I took my seat here in the council. We were having emergency board meetings online during the whole thing, spending money that we were hoping the federal government was going to return back to us. And just like the city of Avalon wanted to get money back, they based ours on population, like they do for everything else in the state, and we didn't get our fair share back. So the hospital is still recovering from not getting its fair share. But we were trying to keep that facility running to take care of the people who were ill here in town. I had ulterior motives. My mother was a patient, lived at the hospital. So it was important to keep all of that going. So we're just like everyone else, we're all recovering from COVID. So.
I guess I'll do it.
Okay.
So, I want to thank you for taking the time, and the audience taking the time to come in, because this is an extremely important issue, and it is, this is my life. I care about healthcare and improving the lives of other people, and a community without a hospital is just not the same. It doesn't have the same fabric, and so I want to explain the history, because I've been doing a lot of deep diving into data and reports and pulling this data so that I can understand our situation. And our situation is, yeah, we are in financial trouble. Am I coming to the city council to ask for money? No, and not in any way. I don't feel that it's not this community's responsibility to fix the current problem that we have. And so I looked in the history of our organization. Good, I pushed the right button. And I looked at our net income since, we started opening the facility in 1960, but I went all the way back to 1975. And as you can see, when you look at this graph, there really has never been until about 2019, 2021, and 23, where we had better profits. But when you look at from 1975, and you see that in 92, we had Memorial Care ceased operations with us, and then AMDC took over. We had about 3 years of good profitability, some profitability there, and then USC took over. And then in 2003, you can see that there was a loss there for that year, but that's when when we became a critical access hospital from a normal PPS hospital. And so that, when we became a critical access hospital, that actually gave us a nice boost for a number of years. And then when you get out to 2016, that's when I came on. And what occurred at that point in time is Dr. Mellon resigned, and also both of them before I arrived. And so, but when you lose your physicians, The only way in which an organization generates revenue in healthcare is with a physician's pen. And a physician has to write orders for those things. And when you lose your physicians, you lose those orders for patients to get care. And then you're also bringing in locums, which are very expensive for physicians, and you have fewer people actually even going and seeing those locums generally. And so we had a loss that year. And in 2017, and this is an accounting thing, but we wrote off a depreciable asset that we no longer use that was worth about $1.7 million, I believe. And so that cash was actually spent years and years and years prior, and we just wrote this off because we didn't use that technology anymore. And then when we get into the pandemic, we had all that money and flow that was going on, and it actually gets really confusing as to when you receive cash and when you record cash and with accounting principles. So, but as we move forward, we look at our investments in cash over the years. You can see, I mean, there really has not been a whole lot of years other than after we became a critical access hospital for a while. And then, I think 2015, we had some cash flow and investments, but it's always been a struggle for this organization. And even though I show that there's cash, when you see that big line in 2020, that's because Medicare gave us a 6-month advance that we had to pay back. And so, and that was just part of the dealing with the pandemic. Our days cash on hand is a calculation of if payers stop paying you now, how many days can you stay open based off of your expenses and how much cash you have? And so there, early on, up until 1983, it was cost-based reimbursement with Medicare. I don't know about Medi-Cal, but back then, you got reimbursed a lot better than you currently get reimbursed. And then, there was that period where there was absolutely no cash in the organization when Memorial was running the place. But then we skip over to 2021 to 2024, and we've just got this double-digit inflation that is just skyrocketing. And the other thing is from 2017 to 2024, when I say 24, I'm talking fiscal year, we've seen our payer mix dramatically change. And the only way within a hospital in a rural market to combat that high inflation or the change in the payer mix, if it's a worse payer mix, is by increasing the utilization of your commercial payers. But you can't increase your utilization that rapidly in an organization, in a small rural hospital. You just don't have the population to do that in the competitive market. So, yeah, we do have financial issues, but we've also had, as you've seen, we've had financial issues for decades. And even when I've been here, we've been to periods of very, very low cash, but the difference is it was a different time. We'd never gone through a pandemic. We've never taken an organization through a pandemic, especially a hospital. It's different than that was the one time in my career where I've said, I don't know. I really don't know what's gonna happen next. But, so we were getting pretty low. So we got down to about $200,000 in the bank. But the difference now is there isn't the low-hanging fruit as compared to when I first arrived here, of things that I could change or we could change as an organization and keep this organization afloat. We've never had in the history of the organization, from what I can tell, anything that is amountable to a serious bank account. A hospital should have generally at least 180 days cash on hand. That's kind of the standard. Mm-hmm. This hospital's never been near that number. But we have been able to, we did get a bolus. We got reimbursed from Medicare for our cost report, and we did get a bolus. So now we can extend with our cash forecast, we're extending out to the end of June. Now, does that mean we're going to make it all the way to the end of June? You know, we have pipes that have salt water going through them that like to burst, and it costs hundreds of thousands of dollars to fix these things. Can we extend it past June? Quite possibly. But what I'm trying to say, and where I'm going to go, and we're going to jump around a little bit, is that the model that we currently are operating in is not going to sustain this organization for perpetuity like it should. We need to change. So as they spoke, we talked about inflation. And when with those numbers that you see on the right-hand side, the blue is what it costs, what we get reimbursed for providing care. The line above is what it costs for us to provide care. And so, as you can see over the years, we've had this, but we've been able to access other funds that are non-operating funds to subsidize the care that we provide. And this is no different from us and other hospitals. We all work in this realm. But we've also had, incredible increases in the expense per patient. Our emergency department, and this isn't, on the left is not our data, that's more from the AHA. And, but what we're seeing in the industry is just huge, as they've stated, inflation. We also, you look over here, and this is another number to the right, where, it shows how our costs have gone up, maintenance. It is so hard to get highly skilled maintenance people that work on technology on an island. And, when I'm talking that, I'm talking about CT machine, X-ray, radiology, lab. And we saw, we had loss of supplies and costs went up quite considerably. And we also had, sometimes I think a few months ago, we had to fly somebody out from Germany to work on our CT machine. But what we've seen is costs going up. And overall, what they've also seen is cash reserves in hospitals going down. Now, because we have technology problems, we're going to have to do this a little different. And we might have to sit in a commercial. Okay. Is there a sound thing that I don't know?
But we found they routinely reject.
Hold on. I think the lower left of that.
The hallways hollow and beds sitting empty. This operating room only a few years ago was doing 5 or 6 procedures a day. Now, 0. Dr. Kenneth Williams is the CEO. He says the hospital can no longer afford the unit or any inpatient care for that matter. All of this used to service people that really needed help, and now it's just totally empty.
It's empty, it's gone, and it died the last few years with Medicare Advantage.
Medicare Advantage is a private alternative to traditional Medicare pitched by celebrity spokesmen like Joe Namath.
Medicare Advantage plans have added new benefits.
31 million people are on the plans, which are often cheaper than Medicare supplements, promise better benefits and lower premiums. But the CEOs of rural hospital systems in 6 states tell NBC News Medicare Advantage routinely denies reimbursements for necessary care.
2006, we went from being well in the black to losing $1.7 million.
Overnight.
Medicare Advantage. And all of a sudden, we went from smiling to crying. And nothing changed other than that.
One government report found that top Advantage plans denied payment for nearly 1 in 5 claims that met Medicare rules.
Your fight is not just to take care of patients anymore. Your fight is becoming more to get paid from the insurance company.
And without the resources to push back, rural hospitals like Dr. Williams's were forced to eat the higher costs. How dire is the situation when it comes to rural hospitals?
more than 300 hospitals that are at immediate risk of closure and another 300 that could be at risk of closing in the next 6 to 7 years.
When Rose Stone retired, she signed up for a Medicare Advantage plan. Rose, how long have you been coming to Dr. Williams' clinic for?
20 plus years.
And did you think if you signed up for Medicare Advantage, you'd be able to continue to do that?
At first, I did.
She was later surprised to learn the plan didn't cover her visits. Faced with paying out of pocket, she made a difficult choice.
I had to stop coming to Williams Clinic.
An advocacy group for Advantage Plans tells NBC News they acknowledge the challenges facing some health systems, but we need to ensure coverage is maintained for millions of seniors. Rose has since gotten rid of her Advantage plan and is seeing Dr. Williams again. You felt like you were taken advantage of.
I know I was. Yeah, I know I was.
Sam Brock, NBC News, Holly Springs, Mississippi.
Thanks for watching. Stay updated about breaking news.
So, one thing that we've seen is a vast change in our payer mix from 2018 to 2024. And when I talk about the Medicare Advantage, you know, I'm kind of lumping that whole talk that he did there on Medicare Advantage with HMOs, with managed Medi-Cal, which we're now being shifted from the old traditional Medi-Cal to managed Medi-Cal. And generally the way this works is you have for-profit corporations or businesses that are managing these things, and they don't pay like regular Medi-Cal or like regular Medicare. It's harder to bill. Everything that he's saying in there is true. But what we've seen is our Medicare go up 3.2%. We've seen our Medi-Cal drop 20%. We've seen our HMO, Medi-Cal, and Medicare, our managed care, go up 18%, and our commercials dropped 3.4%, and our HMO's gone up 4%. So dramatic changes there in combination. So we're getting less reimbursement, and we're getting higher inflation. You look at our ER as the number of people that have come into our facility from 2005 to 2023, and those numbers are so small I can barely read them. But you know, we've gone, I think, 38% commercial in our ER down to about 12% commercial. That's a vast change. Then let's look at Medi-Cal. Because, and everybody, the way this, you would think in your head this would work, is that the line up on top is what we get paid, and the blue is what it costs us to provide care. But it's exactly the opposite. The blue is what it costs, is what we get paid. The line up above is what it costs us to provide care to Medi-Cal patients. And that line is even getting larger over time because we, you know, as with the fee schedule, what we get reimbursed on, it doesn't go up very much in comparison to what inflation goes up. And if you want to understand, when we have HMOs, this is the typical thing that occurs. You know, the blue is if we provided that care as a PPO or a regular commercial insurance, you know, generally what we charge is the green line, and what we get reimbursed is the dark blue. But when it's an HMO, we get reimbursed the light blue. So vast difference in the reimbursement that we receive. What are we trying to do about this? We are working on things. We've tried to, we know that if all we do is convert our license of 4 licensed DP SNFs, which is just a technical thing, to acute care, that we would be able to increase our reimbursement by $700,000 for taking care of long-term care patients. And we've also been wanting to implement our infusion therapy program so people don't have to travel to get chemotherapy or regular infusion for Lyme's disease, and they can stay home and get the same care. But the problem is we've been working through the regulatory process of the state of California for the last year and a half, and we still haven't been able to finalize the changes that they're requiring us to make changes to the patient rooms so that we can just get that change in the license and get better reimbursement. Does that make sense?
Yeah,
And
but
so-
what is it, I'm just curious, what is it But what do you think it's going to cost to be able to get that infusion therapy program underway with all the changes you're going to need to make and all that? I mean, that's got to be a big outlay and people to do it and all that,
It
right?
won't be that. It'll be an outlay,
Yeah.
but it'll be worth it.
Okay.
And it'll be worth it both for the organization by making it more financially stable, and it'll be worth it because it'll take care of people at home. I can't imagine traveling to get chemotherapy and then having to get on that ferry.
No, that's right.
Sounds horrific.
That's right. It's the infusion therapy at home. It's not at the facility. That's right.
No, it'd be at home.
Yes.
At the facility,
Yes.
I mean. Not at
Oh.
home, at the facility.
You're thinking dialysis.
Not dialysis.
Okay.
The other thing that we've been working on, and we had pre-approval before we did this, is we went, during the pandemic, we applied for $750,000 back from FEMA. And we're still waiting to get our final answer as to whether they're going to pay us. We qualified, it's just they didn't understand how complex it was in LA and how LA mandated us to do things like move the physical therapy out of the hospital because we couldn't allow patients into the hospital because we have long-term care in there, and not every state had to do those types of things. I want to get into social determinants of health, which might seem like a little bit of a tangent, but I truly believe that this is a hurting community, and this community has more challenges than most other communities. And the social determinants of health that, project whether, and they have studies that show that economic stability, your physical environment of your community, parks, that quality of education is definitely tied. The higher the literacy rate, the better the health outcome is for that individual 20, 30 years down the road for their entire life. And so, education plays a big role in health, in a person's health. Access to quality food, the community, the safety of the community, and also the healthcare system. But when we look at our social determinants of health, we have a lot of challenges. Just look, and I know that all of you have probably seen numbers very similar to these. And I got these numbers, a lot of these from the census data, but our median household income is $77,000, I think that was in 2020. But comparing all this data that I have up there is comparable data from the same site, from the same year, and everything that our poverty level, it's horrible that we have our poverty level for children under 18 is 25% compared to other communities. Our gross rent, we know gross rent is not $1,600 anymore, but in comparison to those other communities, it's considerably higher. And then you got the median home price, and then you got, I like to go to Best Places because you can see what it would cost to live in a different community, and they actually do rural communities like Avalon, where a lot of web tools don't do that. And with Avalon, you've got, it's 60% more expensive to live in Avalon than average in the United States. And you compare it to Big Bear, Lake Arrowhead, and Mammoth, and it's very expensive. And that 160% also applies to the expenses of the hospital. Home ownership. This one I found extremely interesting. You have most places in California, it's 70% of the people that live in their community own their homes. In Avalon, it's 32%. And the big driver in that is the $1,000 a square foot when I got this data, compared to everybody else where it's much less expensive. These economic and the housing scarcity that we have, can you imagine a single mom that doesn't know if their rental agreement is going to be canceled every week? I know most of my employees have moved multiple times. And now, these days, it's hard to even know if you're going to have it. So imagine the anxiety that goes through that family, that affects their mental health, that affects their physical health, that affects the child's education. These are things that I want as us as a community to address and improve things. The one thing here with education that I pulled off the web is, if you look at our reading proficiency, 30 to 34%, Big Bear 42%, Lake Arrowhead 35%, Mammoth 65 to 69%. And then you also look at our minority enrollment, 81% compared to 49 and 64. We have greater challenges. And being a minority community is a social determinant of health because minorities have greater challenges than non-minority individuals. You look at our social and our community context. You've got homeless students, 8.8%. Our opioid drug claims, now, so what this is this isn't opioid drug that we're necessarily prescribing. It could be from anywhere. Someone goes to town and sees their provider over there and they prescribe it. It's just that that data is tracked with the 90704. But we have higher opioid use in our community than other communities. Health equity.
Hey, Jason, where are those numbers coming? Which website are those numbers coming from?
I can provide you with all of that.
Okay.
I have it's from many different websites, many different places. Most of it's census.
Okay. Thank you.
I think most of that was census.
Okay. Thank you.
Now this video I'm going to play is important to me, and I think this is the most important part of where we're going.
We each have our own history and unique story. The people around us have their own stories and histories. Together, our unique stories and histories shape our world. What you might not realize is that our world also shapes us and shapes our health. Together, our environment and our neighbors make up our community and the fabric of our lives. What would we see if we looked closer at our community and the communities around us? What if we looked just below the foundation, at the roots? Throughout history, some communities have received less than others. Still today, things like housing, income, education, and our sense of belonging in society are not the same in every community or for every person. Yet they directly benefit or hurt our health. But how do these things affect health? Let's take a closer look. Some people live in communities where they have fewer opportunities for better education, fresh food, safe housing, or jobs that pay enough to meet their basic needs. Each person's health depends on their living and working conditions, as well as the resources available to them. Where we live and work and the types of resources we have access to are interconnected, often overlap, and vary within and across communities based on the history, culture, norms, attitudes, behaviors, and lived experiences of people. When we begin to understand that our communities impact our health and we pay attention to the world around us, we start to ask questions. We may start to wonder, what if? What if we could start at the root by investing in our neighborhoods, communities, and larger society? Could we create a world where everyone has the same opportunity to be healthy? Even if it doesn't always seem like it, we have the power to shape the world we live in. We can make things different and better and fair for everyone. We can create health equity. Health equity is the opportunity for all people to be able to attain their highest level of health, regardless of where they live or their personal stories. Addressing health issues at the individual level is not enough. It is far more powerful when we help everyone in a community at once by making changes that affect their physical, built, social, and policy environments. To achieve health equity, we rely on connecting science, policy, and practice to put real change into place. That's where public health can play a major role in helping to achieve health equity. When public health champions work collaboratively with those of housing, transportation, and education, we can move towards creating fair and equitable opportunities for everyone to be healthy. Health equity begins to happen when people in communities engage with one another and explore policies, programs, initiatives, and services that are centered on their shared problems and successes. With the right collaborations and initiatives, we can create a society where all people are healthier, safer, and able to play, grow, learn, and live in places that promote good health. It takes all of us to show up, to have conversations, to decide what resources we need and what actions we can and should take to achieve health equity. Learn more, take action, make a difference. Visit CD.
So, I'll get there. So, as I heard somebody saying earlier before that they didn't feel like we received in our community the same amount of investment as other communities during the pandemic, and because we're on the island. The thing that I find is that a lot of people think because we are from Catalina, we are from Avalon, we are the rich community. And what I have to explain to them is no, we aren't a rich community. We are a struggling community in many ways, because 90% of our workforce was unemployed during the pandemic. It's because we are, our economy is based off of service work and tourism. And these challenges that we have aren't getting the same investment as other communities are getting. And I will argue, and I'm not just arguing, I know it for fact, that our community does not receive the same amount of investment from the state and from the federal government as other rural communities in our state. It's taxes that you, me, well, I should have done that the other way, me, you, all of us pay to the state and to the federal government, and yet those taxes are directed to very specific communities. This is where we get interesting. It's with the supplemental payments. And so the state of California does things different than a lot of other states in many different ways. But, in a lot of states, you are a PPS hospital, you're what they call a tweener hospital, you're a critical access hospital. And in most states, a critical access hospital gets paid the same as all other critical access hospitals. That is not true in California. And the reason why they do these supplements, in theory, are twofold. One is that the theory of that some hospitals see a disproportionate amount of share of Medi-Cal patients, and so they need the supplement. Much like Martin Luther King, definitely needs supplements, needs help. I mean, they are 70% Medi-Cal outpatient, and they are 70% Medi-Cal inpatient. You cannot survive on a hospital. And if that hospital were to close, where are those people going to go and get care other than flood other ERs that are already overpacked in over town? So they give it to the theory is the organizations that get these Medi-Cal supplements are people that see a lot of Medi-Cal, and also to make up the difference between the loss of the fee schedule that you get paid for Medi-Cal and also compared to what it costs. And so they're trying to make it so that you're losing less money on Medi-Cal. So from this, you have the fee-for-service, and then you have 5 different general supplementals. There are other supplementals out there too, but the big ones are these 5. And you can see 19% of the $245 billion that were spent in 2021 go to the fee-for-service, which is how we get paid at Catalina Island Health. Then there's 21% more money that go to those 5 different supplementals and then the managed care payments. So if you look at this, you see all these different supplementals, and there's like in California, $5 billion in the DISH payment, $5 billion in the UPL, uncompensated care, $2.3 billion, hundreds of millions of dollars in DSRP and GME, which GME is graduate medical education. So the universities get that money to help train new people. But then you look in 2021, you look at all the dollars that Catalina Island Health received from those payments, from those supplemental payments. It's not very much. But then look at Lake Arrowhead, mountain community. And I took all this information that we're going to say, I went into their financials, I went into finding things online, their budgets, and also their board packets. And so, but when you look at Mountain Community, they received $8.6 million in 2023, or this might have been from their budget, so that's what they were budgeting. In 2024, they're estimating $8.2 million additional reimbursement that we don't get to have. You look at Mares up in Fall River. I found on their financials $14.8 million in additional reimbursement. They are about the same size as our organization without the long-term care, because they have about a 90-bed long-term care unit. Then you look at Mammoth. If you look at I found this on the very bottom line, the line above the bottom, you can see where they have their supplemental payments as part of their budget. 7 million, 7 million, 6 million. Do you think if we were getting reimbursed like that we would be even up here discussing this today? No, we would be fine. And then you have Seneca Health District. But I think this is a very interesting slide, because when you look at the net patient revenues, they're very close to the size of our organization as a rural critical access hospital. Now, I found $354,000 that we get from a supplemental called QUAF, and that's the only thing we really get any money from. But, with their supplementals, they got another additional $6.6 million. And then when you look at the operating expenses, because they are doing about the same stuff we are doing, I'm estimating, their operating expenses are $21 million compared to our $18 million. This is not a cost problem. All the regulations, the rules, the staffing ratios, the construction costs, everything, I have to abide, and our community and our hospital have to abide by the same rules and regulations as these other organizations that are providing care. But yet they get reimbursed millions of dollars more than what we get. And if they didn't get that, they would have a worse problem than we would have with their net income and their bottom line. So why are these organizations getting these funds? There's all different ways, and there's a lot. It is beyond complex. But most of them that are rural critical access hospitals are tax district hospitals. So you have an elected board of directors, and it just infuses politics into the healthcare system in your community. And then the others that receive these funds are the university hospitals. Basically, you have to have a government tie in order to get these funds. But Martin Luther King, which is a 501c3, a nonprofit corporation like ours, does receive these funds through the county. And I don't know the mechanisms in which those happen, but we're having conversations with Supervisor Hahn and her people, and they're very helpful. And I have to say one thing, but while I divert, your staff has been absolutely wonderful. Dave has been great in helping us navigate the political world, because we're healthcare, we're not politics. Mm-hmm. And I just want to say thank you for his help. But then you have us, we're private without DISH, because we are a 501c3 governed organization. You look at all the critical access hospitals in the state of California, most are now with systems. You have 2 for-profits, then you have all the tax district hospitals, then you have, and this is a little deceiving, because 2 of the hospitals that are on the not-for-profit independent are now being run by for-profit corporations. And out of the hospitals that are on that list, you know, you can't compare us to some of those other hospitals because they're doing hundreds of millions of dollars as a rural hospital. I don't necessarily get it, but when you're running a large hospital, it's the easiest way I can put this is, and running hospitals are complex, but a large hospital is more like it's like a mutual fund. And so when you have a large hospital and surgeries are down that month, you might have radiation oncology, you might have chemotherapy, you might have different service lines that, you know, from the surgery going down, you have other service lines that kind of keep everything in balance and it cooks along as a machine. Whereas with this rural hospital, if the clinic is down, the whole organization is going to be in financial despair for that period of time. So bigger hospitals are easier to run. And so if you look at us, there's really only two really small independent hospitals. There's us and the Colorado River Medical Center. So what makes us different than all of those other critical access hospitals that are receiving supplements? Well, we're all the same. We are rural. We have less than 25 beds. We have laboratory. We have radiology. We provide everything. We provide the care to our community and make sure that when there's an emergency, that we have physicians that are ready to take care of people. There are only two things that are different. We are financially challenged, and we have been financially challenged for decades, and we're a 501c3. We're providing the same services as everybody else is in an environment that is more expensive to operate, and yet we get paid less, and I will argue we get paid less than any other hospital in the state of California. And yet we work in the highest operating cost area. What makes Catalina different? You know, I found an article where it stated that in modern healthcare, where the California Department of Health Services considers us to be, at least in 2001, the most remote hospital in California. But we also have, you know, the cost structure is much different being on the island. I mean, we all know how much it costs to live here compared to when you go to the grocery store over town or you go to a restaurant over town. It is day and night. Those same costs, increased costs, apply to us too as an organization. It's difficult to recruit and retain employees. You know how difficult it is to recruit a physician to our community and you can't tell them where they're going to live? You just got to say, trust me, I promise you I will find you something before you get here. Mm-hmm. It's difficult. And so you have to pay differently in order to make up for the difficulties of living in our community. We have a high cost of living, we have high cost of shipping, repairs and maintenance, you know, anything that breaks at the hospital, we have to bring people over because it's highly specialized. But more specifically, some of the things that I want to point out, and what I did with this slide was I took the data of those other places and I just kind of averaged them on the right. But if you look at us, you know, the things that stick out to me is that we are a minority community compared to all those other communities. And you see that with our percentage of minority population being at 51, the hospital itself is at 68% of employees. And then we have the schools saying that they're 81% of minority. So, you know, I think we all know that our data with the census isn't necessarily the most accurate information out there. But yet, compared to those other communities that have so much more opportunity, they get reimbursed more than we do. So health equity is so important to the California that they created an Office of Health Equity. And I took all this information from their website, you know, health impact of poverty. Evidence shows the strong correlation between poverty level income and cardiovascular disease, low birth weight, hypertension, arthritis, and diabetes. You look at racial and ethnic death disparities. Latino adults have lower utilization of key prevention services than white or black Americans adults. We want to take care of our community. We want to help our community. We want to make this a better place for all of us. But we can't do that when all we focus on, since I have been at the hospital, is trying to make payroll and keep this organization going. It's difficult. You look at, a couple of weeks ago, we had $233,000 in the bank. This year, we got our $88,000 in supplementals. But when I look at the others' financials and their budgets, look at the numbers that they're producing. They're huge. And yet they've got, how wonderful would it be for our community to know that you have a hospital in your community that has cash in the bank, and when something bad happens, you know that you're going to have health care in our town. But look, if those supplementals went away, those other organizations would have very, very serious problems. So, remember when I was saying that what part of the reason why supplementals why they created these are for organizations that have a high percentage of Medi-Cal patients? Well, if you looked at those ones in the blue that have less Medi-Cal, I took out the SNF, the long-term care, because that all long-term care is Medi-Cal patients, and so it really skews the revenue where it's coming from. But if you just looked at hospital care, we're a little above 25% of Medi-Cal. And you look at these other hospitals that are less than us, and they're getting on average of like $8.5 million more than what we're getting. You look at, so in 2014, and I don't know if this number's gone up or not, but all data in healthcare goes back old. But in 2014, 73% of the costs of Medi-Cal were being covered by payments from California with the supplements and everything. But Catalina in 2018, only 45% of our costs were covered. In 2023, 29% of our costs were covered with Medi-Cal. And you can see on the left, that's more of the aggregate of the entire state of California. So this is why I wanted to have this conversation, and that is, we have some very difficult decisions to make. And to me, the decision on the right is a no-go. The outcome of that would be utterly horrific. On average, mortality rates when a rural hospital closes increase from 6 to 9%. It would be much higher in this community, because what happens when weather happens? If somebody is injured or ill or having a heart attack or a PE or anything, they're going to have to sit in that ambulance and wait until the weather clears, and then the helicopter can come in and get them. And most likely, if they have a serious situation, they're going to pass away. Mm-hmm. And that is not really an option for me. We're going to lose our pharmacy. We will lose our clinic. Those things will not be here. And I know people say that we can probably find somebody to open a clinic and run a clinic, but I am telling you, I've done this for a long time, and you can we've got doctors in here. If there was a clinic here and a physician was running that clinic or was in that clinic working, what will happen is stroke victims, PE, compound fractures, real emergency care patients will show up at that clinic, and that physician, a family practice physician, will more than likely say, this is outside of the scope of my practice. I am not trained for this. I don't have the tools. I don't have an ER. I don't have a lab. I don't have radiology. I'm getting on the ferry. I'm out of here. It just won't happen. But we can, and we're working with Alan Lowenthal, or we're working with Assemblymember Lowenthal, and also with our senator, trying to get special legislation, because we're extremely unique, and it has happened before. And I have something kind of written up that would make it so that if we could get something like that, that we would have what I would call health equity as a community. We would be having the investment in healthcare being invested in our community just like every other community. We could do a tax district, but that would mean We would have to go to a vote most likely. The board would have the ability to tax our community. I don't believe that is something that we need in our community, but that would make us eligible for all those supplementals. And I also believe that when you look at the data of tax districts run hospitals, even though they get more money, they predominantly are the ones that fail more often than the 501c3s, because it invites politics and bureaucracy into the system. We could work with LA County, possibly, and we are pursuing all of these except for number 3, or the one on the right. We work with LA County to kind of do something like Martin Luther King is doing, so that they are getting adequate funding so that they can exist. But to me, the thing that I believe what we should do, and will recommend to our board, and I recommend to you, but we want to hear the community's opinion on these things, is I think it is time, when you look at all those critical access hospitals, how many of those are standing alone like us? There's just really only 2. Mm-hmm. It's time that we make the change and join a system or join a large hospital like a Hoag or a UC Irvine or a UC San Diego or a UCLA. But it is my opinion that the best outcome for this community and for our hospital and healthcare in our community is for us to be part of a UC, a University of California hospital. That would give us all the access to all the supplementals. It would give us, and as a hospital, things only get more complex. They don't get easier. I mean, one of the things I fret over all the time is IT security. And, you know, the large hospitals have specialists. We have generalists. And we do have IT, we hire it out. But, you know, we need to become more of a system, in my opinion, and part of that process. And so, to me, the best thing for us to get health equity in our community is to join a UC. But if we can't, I think another system hospital would be a good option, the next best option for us. The special legislation, something like, you know, Catalina gets the mean, the midpoint of all the supplementals that are paid to rural critical access hospitals. But the problem with this right now, it would have been good if we did this a number of years ago, because when we have a $66 billion deficit, it doesn't help. But for us, $5 million, $6 million goes a very, very long way to get us health equity, and really is pencil dust when you look at the California budget. Who we turn to? We have turned to everybody that we possibly can, and we are continuing to work with them. We're meeting with Assembly Member Lowenthal tomorrow, Dave and I, and we are going to continue to pursue all these options before we as a community make a decision as to what is best for our organization. Please reach out to our board of directors. They want to hear from you. They want to hear your opinions, because we serve the community. And let's all work together to get health equity, because what is happening is not right. And we are a community that needs health equity more than other communities. Do you have any questions?
Wow.
I do. I know that we have a list of who we've turned for help already, but given, you know, you've given the numbers of all these cities that we don't get the same amount of financial help, knowing that, who advocates for us and how often do they advocate for us at the legislative level? Not just now, but before. Is there someone specifically that does the advocating for us at the hospital?
The California Hospital Association and the Hospital Association of Southern California, you know, there aren't very many states that have multiple hospital associations. It's just that California is so huge that it can handle 3. But these guys do our advocating. You know, like the other day I was up in Sacramento with Peggy and the other critical access hospital CEOs, a number of them, because we're trying to design a way where we can get better reimbursement for critical access hospitals. And one of the things that has come out is cost-based reimbursement for Medi-Cal. That would change our life. But that still would not give us health equity. We want health equity. Yeah.
So there's
And we-
lobbyists who do stuff specifically for hospitals, where we don't get involved in individual hospital legislation, so that's something
Oh,
that
okay.
is in the hospital.
And I have hired a lobbyist to,
I'm just wondering.
because,
yes.
I understand Medicare. Politics is not my thing.
Right. No, I just see that we obviously need the help, and we've known this for God knows how long. So I just want to make sure that we are advocating at that level often, because we need it.
I have been doing it for years, and I'm always told, hey, go and talk to so-and-so. I think they have a pot of money that you might be able to access. And then you go and talk to so-and-so, and they send you to so-and-so who has a pot of money, and then eventually you're just like, oh my gosh, I can't do this anymore. But now we are at a time when we have to make a decision.
Okay, so none of these decisions are going to happen overnight, right? I mean, I don't know how you're time framing anything that.
My time frame is I can't move fast enough.
Yeah,
I'm moving, I have so many different people involved in trying
Right.
to shore up this problem
Yeah.
and get us health equity, that I'm having a hard time keeping up with everybody. This can't just land on me.
Right.
I need the whole community to help make this happen for all of us. This is not a cost problem. This is a reimbursement issue.
yeah.
That is one large part of it. I will give you that, one large part of it. But I will kick it off. There's, you're just talking about all of this stuff. You're not addressing expenses. And you talk about it's hard to get a hospital people here, doctors and that kind of stuff, because there's nowhere to live. How many units does the hospital currently rent?
Around 20?
20? And are they full 100% of the time?
No, because we're often rotating nurses
Okay.
and other staff.
Okay, and so a doctor can't, you have 20 visiting nurses at a time?
We have different situations. A lot of landlords prefer to rent to the organization rather than rent to individuals. And our most important thing is to be able to get housing for our staff.
Sure, sure. And you purchased a unit in Hamilton Cove?
And
Is
we're
that-
discussing selling it in order to free up some cash flow so that we can buy more time until we get to that, the point where we can say we fixed this problem.
Okay, well, that would be a good step.
So you're saying, though, with the reimbursements you're getting now and that you just got infused 1 point whatever, that you think you could hang on until June?
I think I can hang on till June.
Okay. In the meantime, though, because, one of the discussions we had was the potential for closure and that.
I'm sorry, I didn't hear you.
The potential for closure, you talked about that could happen, even though, God bless, no. I mean, we can't let it happen.
No, we can't let it happen.
I know.
And that's why we're addressing this now.
Right.
Instead of 2 weeks before it happens.
It seems to me, Jason, not to be a jerk, but it seems like you would have known that you were having problems way before you met with me 5 weeks ago, 6 weeks ago. And then I immediately ran to Dave and said, hey, and then he immediately contacted you, and I know, like you say, he's been working with you a lot. It's just, I think what the community kind of wants to know, and maybe I'm asking, it's the elephant in the room, is what has been actually done to cut expenses. Like, I know when we went through COVID, we laid off people, we cut them down. I know you can't do that to a nurse and whatever, but from what the community sees, it looks like nothing administratively has been done to try to reduce costs. It could be all wrong, but that's what we kind of see, and I think that's one of the elephants in the room.
Cutting expenses is not the solution. I showed you, we run a lean shop compared to other hospitals. We run so lean that if we have a specific department that is very small and that individual gets ill, we might have to go days without radiology, or because it's so difficult to bring people in. We should be overstaffing radiology,
Right, right.
not understaffing it. When you are a safety net hospital, you are supposed to be there it's much like your fire department, our fire
Exactly.
department.
We didn't
You
catch that.
staff it and you supply it like, my gosh, we have to be prepared for the worst case scenario. But in our situation, we don't. We drive old golf carts. We own one vehicle that is brand new, and it seems like we're spending too much money. At that time, you couldn't find vehicles to buy, and we need, rather than paying everybody to deliver our stuff, we go and get it now.
Yeah, I understand.
It's not like we are spending money ludicrously. We are a very, very tight organization. And if we did do what you're talking about, which is reduce salaries, we will not have any employees.
If you start at the top, sorry, there is information out there that tells us, and people in this room have researched it, how much a CEO of a hospital comparable size to ours, with the number of beds, pulls down a year. And you are way beyond.
So is this what we're going to do, is just make this all about my
Negative.
salary?
No.
No,
We're
no.
talking about all kinds of expenses.
I'm telling you, there aren't enough costs to cut in order to make up the difference, because inflation is only going to increase, and the payer mix is only going to change even more.
And so the staffing you were talking about, we have such a small staff, so if somebody gets sick, then we might not have radiology. So what exactly does our affiliation with UCI do then? Wouldn't UCI be able to send us an emergency radiologist in that kind of a case? Isn't that why we're partnering with them?
The UCs don't move super fast. They move a little more slower. And we are in the process of developing those types of things. One of the things that right now we've been developing is bringing in more physicians into the clinic to, so that we have medical students there that are far less expensive. But it takes time. Nothing moves very fast when you're dealing with healthcare in a hospital. We move fast compared to other hospitals because we don't have the option to go slow.
I think, and forgive me because I'm getting my voice back, I think that to Mary's point, and not to harp on it because I don't think we need to focus on it for long this evening, the administrative costs of the hospital are a piece of the puzzle, or may need to be a piece of the puzzle depending on how the next 6 months go or longer. So I'm not saying that, I don't know, I love the West Wing. There's a scene in the West Wing where one company has this computer chip, and the CEO agrees that he's not going to lay anyone off, and if he needs to, he'll take a cut in salary before that happens. And it's very altruistic and very necessarily not realistic, which I love living in the idealistic world sometimes. But I was hoping to hear something of like, yes, we can also extend the amount of salary we can pay by perhaps limiting my salary or others' administrative salary for X amount of time if necessary. I know that that may not be something you've looked at, and I know that it's not going to solve the issue, and it definitely won't solve the issue long term. There's a lot of great options that you've put on the paper here that I think are reasonable and make sense and are good for the community and good for the hospital and good for the staff. But I think it's just something to have in the back of your mind and for the board to have in the back of their mind if it comes down to being open or not being open, that may need to be looked at before a solution is in place. Based on a lot of the options, legislation, I'm assuming, would take somewhere between 12 months to maybe 2 years to get on a budget and approved. Same thing with carve-outs for Medicare and Medi-Cal, potentially 6 to 12 months, maybe 18 months. So looking at that and knowing that the summer will usually help pay for itself relatively well, which is good.
But remember, when we see a patient, we don't get paid 60 to 90 days. So,
Right.
we got to figure out how
How
that
to
all
manage
works.
that, right. No,
So-
and I appreciate that. But I'm just saying, I don't know if that needs, I know that your first response is to say it's not a cost of staffing issue, but I also think at this point, because of where the situation is at, it needs to be part of the discussion, even if it's an uncomfortable part of the discussion. It's just something that just is part of it. And then regarding moving towards full affiliation with a UC, I think that that's where this needs to go.
Or it could be an Adventist.
Sure.
Or it could be, but I think the UC, because
Right.
it's got the government connection,
It
gives
provides
us
an
a lot
additional
more
amount of funding,
advantages.
absolutely. It provides additional funding, it provides a greater network for people to also be able to utilize when they're not on the island potentially too. And I think that that's beneficial. So I appreciate you coming tonight, I appreciate you having the difficult conversations. I do think it would be wise to look at the cost of housing that you're paying for and see if there's ways to lower those costs. I think it would be wise to look at everything. Annie's right, when we went through COVID, it wasn't just one thing, one stone that got overturned. It was every single stone. And then after they were overturned, they were squeezed. And so I feel like that's kind of where you guys are at right now, is needing to look at that and make sure that you're already doing some of it, which is great. But I think just continuing to have those conversations and ensuring that we don't get to that last column of options is what we want to do. So I'm happy to help with talking to legislators, whoever we need to talk to be able to make that happen. I don't think that that's a bad thing. I do think that there needs to be some level of oversight returned to City Council that we had lost in the last couple of years regarding transparency of financials, so that this does not get into this place again.
We provide you with our financials every year, the audited
Right.
financials. There's no lack of transparency in that.
We used to get them
And
as
you
a
can
regular
also-
report, though, from
Everybody
you
can
guys.
go on to HCAI and look at our financials for years.
So I
going
actually went
past.
on there
There's
and
no-
couldn't find them.
Huh?
I couldn't find them. If you can send me that link, I would greatly appreciate it. That's where I'm at right now, but I'm sure I'll have more questions as we move forward, so.
Can I ask a question based on what Lisa just said? I mean, she talked, and I agree with her. The legislative process, while it's an option, it's to get on the next legislative session, and we've talked about this, Jason, about
Oh, I
it's going to
agree.
take some time. How long does it take, and I know it's hard to go with a new partner, how long would that take?
It all depends. I mean, it's hard, but once you decide you want to do that partnership, you can do, the partner can bridge fund if we need to, until the whole thing is sealed and dealed and done. That's what we're also looking at is, I don't want a patch. I want a fix.
Right.
This has been decades of patch. And we need a long-term, real fix to secure healthcare in our community. And, but that doesn't mean we can't take a patch to buy us some time. But what scares me is that when you take the patch, then you're no longer the most important thing out there, and you're just delaying the next time you have to get a patch.
If you want to answer this question, fine, but I know these are some of the questions that people are asking. So you have your building fund for the hospital, and things like when you do Catalinaville, the first question is the money that you raised for Catalinaville, which is about $900,000, does
I'm
that...
sorry, I didn't hear
Oh,
you.
I'm sorry, Catalinaville raised about $900,000, I think. It was very successful. Does that money go into general operation, or is that in the or is that in the building fund?
Catalinaville is run by a different organization, not by
The foundation.
the hospital. It's run by Catalina Health Foundation, which has its own board of directors.
Right.
And most of those funds are all dedicated towards construction.
Right.
So I can't take from them to fund operations.
That's you answered the question, but because that's what some of the people wanted to know. So that's good. Okay, that was the main biggie I had.
I'm going to throw my 2 cents in. In 2000, we passed a sales tax to help support the hospital, knowing that, well, a group of people at that time had a search or did a study as to what really would work in Avalon, looking at urgent care, clinic, and what they found was that we needed to have a hospital here, and that hospital was never going to actually be able to pay for itself. And so we passed a sales tax to help that, so that money goes to the hospital. The state legislature decided that all hospitals in the state of California needed to be earthquake-proof. The original date was, I believe, 2015, and when they found out that hospitals were not going to be able to meet that goal, they moved it to 2030. We're so close to that right now. In the almost 16 years that I was on the hospital board at different times, we brought in CEOs, and the focus was always keeping the doors open, but we needed to build a new facility. No one has taken us to that point of being so close to building a new facility other than Jason. And Jason was brought in because he has a background in building facilities. If that hospital goes away, this community will die. We will not have health care on this island. And I know people get mad at me when I give them the gloom and doom, but if that facility is not here, if that facility closes its doors for any reason, it will not be able to open those doors again until a new facility is built, because it is so grandfathered. It doesn't come and meet code in so many ways. That my mother lived up there for 7 years, and there's no air conditioning in the patients' rooms. That just drives me crazy, that they have to suffer through a summer here in Avalon with just a fan going on.
We got portable now.
Okay. But now my mom's not here. But the facility was never intended on this island to have 1 million visitors come and then be utilized by those people. We need to be thinking ahead. And I know there's personality conflicts in all of this, but bottom line is we need to have a new facility. We need to keep the doors going. We need to keep doing what we can do. And the biggest thing that we as a group is to stand behind legislation that we all come together, that we're going to support this facility, this organization, and make sure that we can get out of this slump. But it needs support from us. It's very important that we're united in going to the state legislature, to the governor, and saying, we have to get this done. So that's my big take out of all of this, is that we need to, as an organization, support this organization. So.
Nice to see. Does anybody want to come? Thank you, Jason. It was very thorough, and thank you for doing the presentation yourself. I really enjoyed seeing you up here. Okay, did anybody want to make a comment or ask a question so that they could come back at a later date and let us know? I guess you did answer a hell of a lot of questions today. You did. Anyway, but if you do have questions, you can forward them to them, or if you want to forward them through us, as council members are more than happy to take your comments.
The only things that I have to say is, yes, I agree with you that we need to be in support of keeping the hospital, but I also think it needs to just not be blind support. It needs to be educated support.
I agree. I agree, but no.
Yeah. So I would like to see if we can, especially right now as you're having these challenges, if we could see monthly audited financials given to us and provided as part of, can you hear me? Sorry.
Financials don't get audited monthly.
Sorry, not audited,
annually.
but monthly financials, just so we know what your current status is, even if it's a report just to the city manager that he can provide to us, just so we make sure that we're keeping abreast of it and are able to speak educatedly when we talk to others as well. I'd appreciate that.
And is your board up to speed on all of that? I mean, how
My board is highly educated on everything that I've spoken about.
Okay, just curious how it just came to be such a, all of a sudden.
I haven't gone,
No, but it just seems like it's just all of a sudden a panic.
It takes a long time to understand how all these other things work in this state, the regulations. I cannot tell you how many hours I have spent over the last month just reading regulations, because it is so, how much more complex is California than where you came from?
Well, significantly, and I would say a month ago I started diving in and learning hospital law
Yeah.
and regulations.
Fun,
It's-
huh?
it's, no, it's not fun. But, yeah, the city is fully supportive of trying to fix the problem.
Right.
We're all on the same page of what we want to see
Right.
as an outcome.
But please.
Can you
I'm sorry,
come to the
up,
microphone,
yeah.
please? Otherwise people
People
can't
at home want to see your handsome face.
There are a lot of hospital CEOs right now going, blah. So it's not just this hospital and this city council and this hospital board that's hearing this from their CEOs. This is happening throughout the state. So, and I've been doing this for 30 years, and I have not seen it this dire since probably the late 90s, where we have hospitals that are on the precipice. And so to hear your support for this organization really says a lot, because this is an important hospital for this community. So it was just rewarding for me to be here, to hear a city council get this engaged. And so thank you to you for your leadership.
We're just a little small family community, so we're all very concerned about stuff as it happens, you know?
And don't get me wrong, Jason, I'm not attacking you at all. It feels like you feel like I'm attacking you. I'm not. I'm just asking the questions that are out and around there. I do know that we need the hospital. I support the hospital. You know, I love the hospital. I sincerely wish that things that have happened in the past with several people exiting did not come to that. And I think that would have helped in some of the expenses quite a bit. So, but I like Lisa said, it's because of this whole thing, all the expenses, it all has to be looked at. And we are all going to work together, the community, everyone, work together to get through this. You can come up and speak. Right?
Mary, you bring up an interesting point. I'm Jack Sweeney. I think we would all have a lot more confidence going forward if the financials that have been mentioned as being published over the last few years were audited. I think an audit of the operation of the hospital, which is insulated from the city by the agreement with the city, as I understand it. An audit would be the perfect foundation to go forward with a new relationship with any of the hospitals that have been mentioned, and it would lay the groundwork for confidence that we knew what we were doing in approaching them. This presentation is fine. I'd like to see us go forward with a relationship that gave Avalon the facility that it needs and has really enjoyed for many years. This has been an enormously successful operation, and now we're told that it's about to fold up. I think we need to look back a little more intensely before we start planning and seeking the money that's needed.
Thank you for your comment.
Thank you.
And I just want to make a real quick reply to that. Just as the city's financials are audited every year, an auditor comes in and does financials for the hospital. And I can tell you it's not fun because my sister works in the billing office and she hates audit time because she has so much work that she has to do pulling files. So those financials are audited every year, just as the cities are.
Yes, we have been for years, for the past, I think, 6 years, we've been audited by BDO, which is one of the nation's largest auditing firms so that other hospitals use, and now we have switched because you should switch every now and then. And now we are audited by Whipley, which Whipley is a large accounting firm for the state of California, probably the largest. And then after we have our financials audited, we provide them to the city council. So we are, sorry, sir, but we are doing everything that you requested.
I guess along that line, it's more of, I know when we get our warrant requests and things like that, we know how much is going out every month, and we can see in a simple, this is the revenues, this is the expenses and admin, this is the doctors and locums and this is our housing costs every month. That kind of stuff, I think, is what maybe we shouldn't be privy to, but I think that's the kind of questions that people want to know, to say, is that really, does that make sense? Am I kind of on base there with what I'm saying?
It makes total sense.
Yeah, so, that's all.
Do you know the website offhand, by the way, where it's posted? Just because still don't see it on your site.
ACAII.
Okay, I'm gonna look it up. Thank you.
Okay, did you find it?
No.
Oh, okay, still, okay. Anyway, does anybody else want to make a comment or ask a question? Wow. Okay, well, we good? Everybody's good? All right.
Oh, sorry. Are we doing another one of these with an update on the state of things? And if so, when? And
Good question.
thank you.
Yeah, I think, I mean, if I could, as soon as we get something to report back on, we'll talk to Jason and his team about getting them on the agenda.
Okay.
Okay, and then I think another one in the future is the status of the new hospital and how we're doing and that kind of thing is very important, because as we know, it was going to be a $60 million project, and now it's quite a bit more, so I think there's a lot of curiosity.
And the longer it takes, the more expensive it's going to
I
get.
I understand.
Is that possible on the plot of land that it's on?
Huh?
Is that possible?
Is what possible?
On the plot of land that it's on? The amount?
What?
I think, okay, if sometime in the future, we could have the status on the hospital, the new hospital. Fred, were you going to talk, or are you getting ready to go?
All the gloom and doom about the hospital closing, is there any kind of a plan to maybe put in an urgent care in the meantime if they do close?
I think if that happened, it would be up to LA County, correct?
But, you know, like my son, he always goes to urgent cares, and he lives in Culver City. He doesn't
Right.
go to
Yeah.
a hospital.
Right.
And I know here, they medevac you off if anything serious happens.
Yeah.
Is there any contingency plans on putting in a good urgent care and maybe a nice rest home facility here?
Yeah. So you've spoken about the urgent care, the working or not being able to work here, right? It seems like, Jason?
Well, I mean,
Oh, okay. Is there a doctor in the?
there's
is there-
urgent cares all over.
Yeah, there's a few.
Fred, there's a doctor in the house.
Okay, well, anyhow.
Well,
They were.
he's gonna talk to that. Thank you.
Yeah, thanks for that question. My name is Chris. Get on the mic here. My name is Chris Fox, and I'm an emergency physician. I'm also on the board, and I work at UCI. And this has been an awesome meeting. So many great questions in the room and everything. And but the question about an urgent care comes up all the time. You know, it's like, could the island survive just with an urgent care? It's a very common sense question to ask in this situation. Could we bridge to the new hospital to urgent care, things like that? And I could tell you that there's on both spectrums of care, the reason why that would frankly scare me, because there's a spectrum of care in which there's somebody who we're just trying to stop them from dying in that moment, and the paramedics are very helpful here. Avalon Fire are amazing. We work really closely with them, but at some point, their license stops, and ours, the emergency physician's license, takes from there. And it's in that first sort of hour of life or death that we really do intervene often on this island, in a surprisingly amount of time. And the 7 years that I've been working here, and my team's been working here, we have story after story after story, and it feels really good as an emergency physician to provide that care here. We love it, actually. It's really impactful. On the other end is people that we can kind of reverse the situation and keep them on the island. And so there's a lot of cases like that, whether it's a glucose is too high or something with a kidney or somebody faints and, a protocol might be, oh, they fainted, they got to go. But, we talked a little more, realized it's more like a vasovagal episode and some fluids, some dehydration. We keep a lot of people on the island. And I think you would need, as an urgent care, it'd be really tough to be in that situation. Suddenly you're presented with a really sick patient over and over again, and you wouldn't have the training or the facility in order to provide that level of care. So I think that wouldn't be the right solution here. As much as it is tempting to do something like that, it's a lot simpler. I don't think it's the right thing based on just 7 years of experience here.
Okay. Did that answer your question, Fred? Okay.
I think to Fred's question also, as much as we don't want to look at that last column of contingencies, those discussions have already started happening of what happens if or what happens when. And so it wouldn't necessarily be that the city would be high and dry on medical care. There would be steps to take to be able to provide care and service if the last column of issues were to go down. If that was to happen, it would likely be LA County that would step in to provide help, I believe, is what I've heard from discussion, so.
I mean, we're obviously exploring those answers if the worst case scenario happens.
Right.
Yes.
So it's being looked at, there's just not answers yet because we haven't gotten to that point yet.
Any other questions or comments before I close the meeting? Thank you very much, everybody, for coming, and meeting adjourned.